If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome. I'm Fernando, a GP in the UK. In today's episode, we'll be looking at the NICE updates published in April 2025, focusing on what is relevant to primary care only. We've got another short and snappy episode today, as there are only two clinical areas to discuss: the brand new national guideline on fall prevention and new advice on cancer recognition. Right, let's jump into it. And let's start with the update on the cancer recognition guideline, which affects the recommendations on blood tests for myeloma. These recommendations have been amended in response to a series of reviews to improve early diagnosis. So now, those with unexplained fracture or persistent bone pain, particularly back pain, and especially if they're aged 60 or over, should be investigated for myeloma, although we can consider it for people under 62. For this assessment, we will request the following blood tests: the full blood count, serum calcium, either plasma viscosity or ESR, paraprotein using serum protein electrophoresis, and serum free light chains. If the serum test is not available, we can use a Bence-Jones test to check for free light chains in the urine. The change means that we should now include serum protein electrophoresis and serum free light chain testing in the initial diagnostic blood test. And this testing should be offered instead of the traditional urine test for Bence-Jones protein. The second section refers to a brand new guideline on falls assessment and prevention. These recommendations are for people who are aged 65 or over, or aged 50 to 64 with one or more factors that could increase the risk of falls. These factors include long-term conditions such as arthritis, dementia, diabetes, Parkinson's disease, having had a stroke, and having a learning disability. The guideline recommends a comprehensive assessment and management plan for these patients. But who should we prioritize? Well, we should offer comprehensive falls assessment and management to people who have fallen in the last year and who are frail, were injured in a fall, have experienced loss of consciousness related to a fall, have been unable to get up independently after a fall, or that have had 2 or more falls in the last year. For people who have fallen in the last year and who do not have any of these criteria, we should assess their gait and balance. And if they have a gait or balance impairment, we will simply offer a falls prevention exercise program and a home hazards assessment. But let's go back to the people in the first group, those at highest risk and the ones that need a comprehensive falls assessment. What should this assessment include? Well, we should check for alcohol misuse, perform a neurological and cardiovascular examination, including a lying and standing blood pressure. We will do an osteoporosis risk assessment, including the risk of fragility fractures, a review of medication and long-term medical conditions, and also include an overall review of the patient, looking at things like cognition and mood, diet and weight loss, hearing and visual impairments, dizziness, functional ability, urinary continence, gait, balance, mobility, etc. And once we have done this assessment, what does the comprehensive falls management entail? Well, apart from addressing obvious issues identified in the assessment, this management plan should include a structured medication review. And for those on psychotropic drugs, we should discuss their increased risk of falls, considering stopping these medications, liaising with specialist services if necessary. Psychotropic medicines include antipsychotics, antidepressants, anxiolytics, mood-stabilizing agents, and antiepileptic drugs. Then we will refer to occupational therapy and any other appropriate service for a home hazard assessment and a fall prevention exercise program. We will also consider the need for surgical interventions such as cataract surgery or a pacemaker if these problems have played a role in their falls. And finally, although there is insufficient evidence to support taking vitamin D supplements, Specifically to lower the risk of falls, we will encourage people to follow NHS advice on taking vitamin D to maintain bone and muscle health. For adults and children over 4 years of age, this advice is that they should consider taking a daily supplement containing 10 micrograms or 400 international units of vitamin D during the autumn and winter months, generally from early October to the end of March, and this includes pregnant and breastfeeding women. Between early April and the end of September, most people can make all the vitamin D they need through sunlight and from a balanced diet, so they may choose not to take a vitamin D supplement during these months. However, people at risk of vitamin D deficiency, including the frail and the housebound, and also those with darker skin, for example those of African, Caribbean, or South Asian background, should take 10 micrograms of 400 international units of vitamin D throughout the year. The advice for infants and children under 4 years of age is slightly different, and it is not covered here. So that is it, a review of the NICE updates relevant to primary care. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.